Hi everyone, great to see you all again. Our virtual conference, Radiopedia 2023, is now just over 3 months away. Lots of work is going on behind the scenes as we make sure that all the lectures, the workshops, the panel discussions, the review questions and the English subtitles are all ready and polished ready for you. Remember that registration is open and there are a few different options that you have. If you reside in one of the 125 low and middle income countries listed on our website, you could be eligible for free access. You could purchase an all access pass, or you could purchase registration for the conference only. And remember that tiered and concession pricing options are available. As soon as you've registered, you will be given immediate access to 11 encore lectures. These are some of the best lectures from previous conferences, so you can get warmed up for the main event itself. Now, we've also been busy reviewing more than 500 abstracts that we received for the brand new R poster feature for this year's conference. They were of an incredibly high standard, and we are really pleased to have you, the community, being a part of the conference this year. Okay, so let's get to this week's lecture. This one is by Heather Moriarty. Heather is an interventional radiologist at Cork University Hospital in Ireland, and she trained in IR at the Alfred Hospital in Melbourne, and she's a specialist in vascular and oncology interventional radiology. This lecture is titled Tips and Tricks for Image-Guided Biopsies and Drainages, and I think you'll find that whatever level of IR you practice, there'll be something useful for you to take away from this lecture. By the way, did you know that Heather was featured in a recent episode of our podcast, the Radiopedia Reading Room? Have you been listening to it? And if not, why not? Andrew Dixon and Frank Gaillard are the hosts, and a new episode drops every week, and you'll find it available on almost all major podcast platforms. And just like with this YouTube channel, if you don't want to miss a thing, make sure you hit like and subscribe. Okay, let's get started with the lecture. Here's Heather Moriarty.
Hi everyone, thanks for tuning in. I'm Heather Moriarty. I'm an interventional radiologist in Melbourne, and I'm going to talk about the basics and some tips and tricks for percutaneous biopsy and drainage procedures. I'll focus primarily on biopsies and then touch a little on drainages. So biopsy and drainage procedures are safe and effective procedures. Percutaneous drainage has significantly improved patients' morbidity. Biopsies are key to guide therapy, more and more so in the era of molecular profiling and immunotherapy. There are a number of things you need to think about before the time of the procedure. The indication procedure should be discussed, including the type of biopsy. You often need more tissue for molecular characterization, so make sure you know what medium you need to send it in, for example on saline soaked gauze or in formalin. Also, patient factors, comorbidities, anticoagulation status should also always be known. Regarding the imaging, if there are a number of lesions, such as in this case, then choose the lesion with the safest route. Aim for an area with contrast or PET avidity so that you're more likely to get viable tissue. You should also consider your equipment, which imaging modality, and also what could go wrong and how to minimize the risks, and what to do if you do have a complication. Do you need to have a chest drain in the room, for instance? Percutaneous needle biopsy include fine needle aspiration biopsy and core biopsy. FNA uses a smaller gauge needle, usually 21 to 25 gauge, to get cells for cytology. A syringe is attached to the FNA needle, and usually with suction, the needle is oscillated with short in and out movements. Some of the literature with the best results for FNA have a cytopathologist present. FNA has been around for a long time, and there is still a role for it, though core biopsy is much more common now. Core biopsy uses bigger needles, usually 9 to 20 gauge, and results in a piece of tissue for histology. By far the most commonly used are automatic or semi-automatic core needle biopsies, and the length of the throw is usually 1 to 2 centimetres. Some manufacturers allow you to adjust the length of the throw for the biopsy. There are a whole range of other needles like steerable and blunt tip for helping with access routes, and others like end cut, screw tip, oscillating or vacuum assisted, which can be used to try to increase the tissue yield for particular situations. Most biopsies, except the very superficial or the very high risk, are generally day case procedures. Ideally, we schedule most biopsies for the morning, and that's just a practical thing so patients can be monitored for the required length of time and then either discharged, or if a complication does happen, it can be managed within hours. This is also important for your pathology lab, particularly if there is time-sensitive processing necessary for the specimen. So just be aware of what the practice is at your institution. Regarding hemostasis, there are so many anticoagulants to know, but the good news is there are guidelines available for most situations. You may have local guidelines, but I often refer to the CIRSE guidelines for anticoagulation. This is a table from the 2017 CVIR patient paper. You can see the biopsy type here is categorized as low, moderate, or high risk, such as renal biopsies. In general, most biopsies and drainages except the superficial are in the moderate risk category. So these are the recommendations for moderate risk procedures. INR should be corrected to less than 1.5. Usually a platelet transfusion is recommended if the patient's platelets are less than 50,000. Aspirin is not usually withheld for a moderate risk procedure, whereas clopidogrel, therapeutic dose, low molecular weight heparin, and NOACs are. When stopping anticoagulation is a problem, for instance in a patient with a high thrombosis risk, then that's a discussion of the risks and benefits. Prophylactic antibiotics are not routinely given for most biopsies. As long as the aseptic technique is employed, the risk of contamination is low. Generally, the only time this changes is if your route is non-sterile, such as transrectal prostate biopsies, or occasionally in an immunocompromised patient. For abscess drainages, on the other hand, the patient should already be on an antibiotic. If they're not, I will give an empiric antibiotic because patients can have a septic episode if you manipulate an abscess. If you're giving prophylactic antibiotics, they should be given within an hour of the procedure. If more than 2 hours has elapsed, then you should give a repeat dose. Giving antibiotics after the procedure is not ideal. It translates to about 4 times the risk of infectious complications, which is equivalent to the rate of infection when no antibiotic prophylaxis is given. Choice of imaging modality is really important, not only to see the lesion, but also to see the adjacent structures and the equipment you're using. When the lesion is not visualized on some modalities, it may be visualized on others, or you can use techniques to enhance the visibility, like optimizing your ultrasound imaging, windowing, contrast enhancement. There is no single best imaging modality. All have advantages and disadvantages. If you have a choice, use whatever you're most comfortable with, and don't forget to consider 2 modalities like ultrasound and fluoro, or CT and fluoro. There are some real benefits to ultrasound. It's real-time imaging. You can see exactly as your needle traverses the tissue planes. It allows you to follow respiratory motion. It's also very easy to deviate from the axial plane or alter your course in real time, and the lack of radiation is a really big benefit. CT has certain advantages too. It has excellent spatial resolution. It's particularly useful in the thorax and when there's bowel close to your path. CT fluoro can be very useful for performing difficult biopsies, as you have almost real-time imaging. I have to say I don't use CT fluoro very often. I tend to walk in and out of the room to minimize the operator dose. I use CT fluoro generally just if my patient is very restless, or if whatever procedure I'm doing has a particularly time-sensitive component. The combination of fluoroscopy and ultrasound I like a lot, perhaps particularly for performing drainages with the Seldinger technique. It helps avoid loss of access or guidewire kinking during a tract dilatation. Cone beam CT can be useful, particularly if it's difficult to get CT time. MR and PET CT have a few unique benefits. Generally, time is more costly in MR, but it is useful for soft tissue lesions because of the intrinsic high contrast resolution. PET CT guided biopsies are rare, but lesions that you can't see on traditional imaging, it may be useful if they're hypermetabolic. A benefit here is that you can scan the actual biopsy sample and immediately know that you've got the right spot because it's AVID. We know from the aviation industry that having a pre-procedure checklist minimizes the risks, and this is proven true for procedural-based medicine as well. This is the CERSI checklist, which is available to download and modify from their website. It can help you remind you what to check before the procedure, consent, allergies, equipment, and know that everyone in the room is on the same page. Obviously, it's important to make sure your patient is comfortable. And it sounds banal to say it, but it's really important to make sure you're comfortable too. Try not to overstretch to reach your needle, have the lesion close to the operator, the patient close to the edge of the bed. These small things can help a lot if it's a lengthy procedure. When positioning your patient, make sure they're comfortable and in a stable position, particularly if you're using local anesthesia alone. The worst position that your patient could be in is to be a moving target. It's important that when a patient can see parts of the procedure, for instance, a biopsy or drain for an anterior approach, it's really important that you've described what they might see before the procedure. It can really help reduce anxiety during the procedure when there is, for instance, an 80 centimetre Amplatz wire coming out of their chest or whatever else. Ipsilateral decubitus is a useful position. It can potentially decrease the risk of pneumothorax for lung biopsies. It's also useful in the upper abdomen. It reduces motion of that hemidiaphragm, and the less movement means the less complications. The dependent lung can also deflate a little and move out of the costophrenic recess, which decreases the risk of lung transgestion for upper abdominal procedures. Sometimes just changing a patient's position can move structures slightly, so think carefully about that for challenging procedures. It can, on occasion, convert an undoable procedure into an achievable one. Selection of an access route is obviously critical. Generally, you want to pick the safest, straightest, shortest route and avoid all risky structures like lung fissures, bullae, vessels, or whatever may be close by. Usually, the less angulation, the better, so perpendicular is ideal when possible. Of course, sometimes a little or a lot of angulation is necessary in the mediolateral plane or the craniocaudal plane or both. You also need to consider your tract in terms of whether the patient is having surgery in the future. In some situations, an R0 resection can only be achieved if the biopsy tract is excised. If the route is through a single compartment, that's ideal. For example, for a retroperitoneal tumour, don't go through the abdominal cavity to biopsy it, stay retroperitoneal. There are some situations where a longer route is preferable. For subcapsular liver lesions, a longer tract with interreading normal liver reduces the risk of hemoperitoneum and the risk of tract seeding. And sometimes in small lesions, you may have to use a longer route to biopsy the trajectory of the long axis of the lesion. What size biopsy needle? Well, there is no simple answer to this one. It depends on a number of factors, like how much tissue is needed, the lesion location, size, tissue type, and so on. The more and the bigger samples tend to increase diagnostic accuracy up to a point, but will also increase the risk of complications. The best thing to do is chat with your pathology team and audit your adequacy rates to make sure you're achieving standards. The next few slides are a very general guide to the needle gauge that I most commonly use for each indication, but I have to stress that it's really just a general guide and it depends on the clinical scenario and what clinical specialties are even available at your institution and so on. So for diffuse liver disease, a non-targeted biopsy may be performed. Adequacy is really enough tissue to provide sufficient information for the clinical requirements, and that depends on the clinical scenario. As a guide, adequacy is generally considered to be more than 11 portal tracts. Generally, a 16-gauge biopsy is recommended, and the core should be about 2 to 3 centimetres in length. Studies in patients with viral hepatitis showed that grading and staging accuracy is reduced in biopsies less than 2 or 2.5 centimetres in length. For focal lesions, on the other hand, I use a co-axial technique and take multiple passes with the biopsy needle, generally 4 or 5 passes. For a non-targeted renal biopsy, the diagnostic yield is usually dependent on the number of glomeruli per specimen. At least 10 glomeruli is generally required for an adequate specimen, but more is preferable if the disease is focal in nature to reduce the risk of the pathology being missed. So for renal, again, 16-gauge cores are recommended. There's heterogeneous data, but a 14-gauge biopsy needle tends to increase the risk, the complication rate, whereas an 18-gauge biopsy needle tends towards inadequate samples without a significant difference in complication between 14 and 16-gauge biopsies. I tend to take 2 16-gauge cores. For a focal renal lesion, again, I use a coaxial needle so I can take multiple passes and minimize the risk of tract seeding. For a renal biopsy, it's usually a cortical biopsy, and I try to direct my needle towards the poles. Usually superior to inferior is easiest, and you get the maximum number of glomeruli, and also you're aiming away from the blood vessels at the renal hilum. It's important to manage hypertension prior to renal biopsy, particularly in the renal patient, because there is data to show an increased risk of bleeding, actually up to 10 times the risk of bleeding when the blood pressure was above 140/90 in one series. Just a note on small hyperechoic kidneys like this left kidney. This generally suggests irreversible advanced chronic renal disease. Usually a biopsy in these patients doesn't tend to yield clinically meaningful data, and the complication and adequacy rates are worse, so these are generally avoided. For lung lesions, either a 17-gauge coaxial and 18-gauge biopsy needle, or a 19-gauge coaxial and a 20-gauge biopsy needle are usually chosen. There is good evidence to say a 19-gauge with a 20-gauge biopsy needle is fine, although you may need more passes with a 20-gauge needle, particularly for molecular analysis. The trade-off with a larger gauge biopsy is a higher rate of pneumothorax. So I generally take 4 or so passes with a 20-gauge biopsy. Biopsy side down, as I've mentioned, is a useful position for lung biopsies. It has the benefit of reducing the risk of pneumothorax, decreasing motion in that lung, and if there is hemoptysis, you want to keep the patient in the ipsilateral decubitus, or the biopsy side down position. Remember that as little as 100 mils of blood aspirated into the contralateral lung can cause significant hypoxia. So splenic biopsies are uncommon, generally performed for focal splenic lesions, but occasionally the splenic parenchyma itself is targeted. If I'm doing a splenic biopsy, I always use a coaxial needle, and I always embolize the tract, usually with glue, but a number of embolics are fine. The authors Tam and Olsen both had similar diagnostic accuracy and complication rates in splenic parenchymal or lesion biopsies. The vast majority of these weren't coaxial, and the needle gauge was between 18 and 22 gauge, with a variable number of passes per patient. For prostate, I usually use an 18-gauge biopsy needle, and the number of passes depends on whether it's targeted or systematic or both. For bone biopsies, a drill is a great tool. It makes things a lot easier and a lot faster. It's essential for sclerotic lesions, really. I use a 10 or 11-gauge coaxial needle and generally take about 2 passes through sclerotic bone, and if the lesion is lytic, advance the 11-gauge coaxial to the lesion, and then use your standard soft tissue automatic core biopsy to take multiple samples, usually 5 or so. You can get crush artifact with sclerotic lesions in bone. That often, I think, happens when you're trying to get the specimen out of the needle biopsy. And if a lesion is very sclerotic, more numerous but shorter samples, such as, a number of 5mm samples rather than 1-2 centimeter samples, can help you get the sample out of the needle. It's very difficult. If it's very difficult, you can use the trick of warming the biopsy needle. For instance, use warmed saline or whatever you have to hand to warm the metal, and that expands the metal and helps get the specimen out. For superficial lesions, bleeding can generally be controlled with manual pressure, so larger gauge can be used more comfortably. So for a superficial lesion, I'd use a 14-gauge biopsy and take 3 or more samples. For deeper soft tissue, again, I use a coaxial needle, generally 17-gauge, and take a number of 18-gauge core biopsies. Vitals should be monitored before and during the procedure, particularly in moderate and high-risk procedures. Consider the potential complications before you start. If pneumothorax is a potential complication, then have a drain set in the room before you start. Peripheral venous access is always something to think about. Aqueous-based solutions like bethadine are one of the few products that can be safely used on mucous membrane surfaces. Otherwise, chlorhexidine solutions are ideal. Optimizing local anesthetic goes a long way. Usually I use 10 to 15 mils of lignocaine along the needle path. The lowest effective dose is what you're aiming for, but do make sure it's effective. A big element of that is making sure that you use the same tract that you anesthetized. Obviously use the local anesthetic for the skin and subcutaneous tissues, but you also need to anesthetize the deep structures that are pain sensitive, like the pleura and the peritoneum. When you are giving local here, try not to breach the tissue. For instance, give the local just superficial to the pleura or the liver capsule, but don't actually breach the capsule. The need for sedation should be planned with your patient pre-procedure. Short-acting sedatives and opiates are very useful. In a well patient, I might start with 25 or 50 of fentanyl and 1 milligrams of midaz. The onset of midaz is about 2 minutes and 7 to 8 minutes for fentanyl. Sedation obviously causes physiologic depression, so it goes without saying that you need to have appropriate training, know your reversal agents, and know where they are if you want them in a hurry. Just a word on breath holding. In general, I try and do most procedures with normal or shallow breathing. Explain to the patient not to take really deep breaths in or out, just to try and reduce the variability of breath holds. I do watch the patient's respiration and time my movements based on that. For instance, if I'm removing the stylet of a coaxial needle during a lung biopsy, I'll do that during a patient's expiration and make sure my finger is on the hub during the inspiration. If you do want patients to breath hold, it's considered most comfortable in submaximal inspiration. Sedation is something else to consider. Too much can mean you don't have the patient's cooperation for breath holds, but obviously too little can be detrimental as well. So there are a number of techniques for biopsy, simple, coaxial and tandem. Simple is the standard biopsy technique. The needle is advanced into the tissue, sample is taken, and you essentially start from the start each time you want to take a pass. So coaxial is a really useful technique. This is where a guide needle larger than the biopsy needle is advanced to the edge of the target. The inner stylet is removed. A biopsy needle is introduced into the guide needle, and then as many samples as necessary are taken. The inner stylet is then reintroduced before you remove the coaxial needle. I always use the coaxial technique for biopsies where the route is difficult. I use it for all targeted biopsies where I think I'll need multiple passes. Tumour seeding is a really rare complication of percutaneous needle biopsy, probably higher risk for particular tumours like HCC and papillary renal cancer. Multiple punctures of the tumour capsule likely increase the risk of tumour seeding, and using a coaxial technique can decrease the risk. I also use a coaxial technique when in a particularly high bleeding risk procedures because it allows for embolization of the tract, which I'll come to. The tandem technique is the last technique. It's use of side-to-side needles, such as an initial 23 or 25 gauge needle, which can do very little damage. And then when you're happy with the trajectory and depth of, you place your biopsy needle alongside. The disadvantage of this, of course, is that it requires multiple punctures. When taking multiple samples, I am generally using a coaxial technique, and when I do this, the aim of the biopsy needle should be redirected very slightly each time to maximise the actual tissue yield collected. The inner stylet of the semi-automatic needle can also be bent a little manually to get multiple cores in different positions. You can then rotate the needle to change the trajectory when coring. Be careful only to put a little bend on as you can get the needle stuck in the coaxial system if there's too much. Cross-sectional imaging with IV contrast prior to the procedure should be performed in virtually all cases. Don't forget the contrast doesn't just come in the IV form. Sometimes oral contrast with water or effervescent granules or air injected through the NG tube can be useful. Contrast uptake is suggestive of viable tissue, so when you're planning, the aim is to biopsy a component of viable tissue. In some situations, IV contrast is needed at the time of imaging to visualize the lesion or components or surrounding structures. And this includes contrast-enhanced ultrasound, which can be useful, for example, for this cholangiocarcinoma biopsy. It can be helpful to plan based on non-contrast and save the contrast injection as a late step. This renal lesion was difficult to see without contrast, so here I gave contrast after the local in biopsy mode, so there was still contrast enhancement of the structures while actually biopsying, which can increase confidence with needle placement. If you're using CT and getting too much streak, sometimes pulling back the inner stylet of the coaxial needle helps reduce streak at the needle tip. Needle tip visualization depends on a number of factors such as needle type and size, scanning angulation, but there are some simple maneuvers that can help, including shaking the needle, moving the stylet within the needle, or even injecting a small amount of saline or lignocaine to help see where the tip is. Usually, manual compression of the puncture site for a few minutes is necessary to prevent bleeding. On occasion, embolizing the tract can be necessary. Tract embolization can be really useful, particularly in procedures where there's a higher bleeding risk or to reduce the rate of pneumothorax and lung biopsies. So here the biopsy needle is removed and the embolic is injected through the coaxial needle. There are a number of different embolics available. You can use autologous clot, either from a venipuncture or if there is bleeding through the coaxial needle, cover the hub so the blood products clot within the coaxial needle, then advance the stylet as you're withdrawing to push in the autologous clot. I find autologous clot works best in low flow lesions. If there is a higher bleeding rate, I will use gelatin sponge or another embolic. This is a video of how to make gel foam slurry. You mix the gel foam or gelatin sponge with saline or with contrast using a through-8 tap about 20 times, and then inject the slurry through the coaxial needle as you're withdrawing. Usually 2 to 3 mils is plenty. At the moment, I use this technique at my discretion on a case-by-case basis. For instance, if I'm biopsying a highly vascular lesion or viscera, or there is some element of coagulopathy. So deviating a little to talk about drains. What size catheter should you use? This essentially depends on what you're draining. I use as small a catheter as I need. So for simple ascites or pleural fluid, I might use a 6 French drain. For purulent material, usually a 10 or 12 French. And for something like a necrotic pancreatic collection, generally a large bore drain like 16 to 28 French is necessary. Trochar technique is essentially a direct stick with the drain you're placing, so it's great if the tract is very direct or the collection is superficial. You confirm you're in position by aspirating. You have to remove the inner stylet. If you get what you expect, then hold the inner stiffener still and advance the plastic drain off the stiffener to form the pigtail. Seldinger technique is a puncture with a hollow needle, then a wire. I tend to use an 80 centimetre stiff Amplatz wire because it's stiff enough to support the drain. A softer wire can risk kinking or losing access. You may need to use a dilator or forceps to dilate the tract before you place the catheter. It's more controlled than just pushing against resistance. In general, I favour a Seldinger technique, especially for deep collections, and during your early training or career, it can be comforting to know that you're in with a small needle before you put your drain in. If there is an existing drain, this can sometimes be manipulated to improve position, or for instance, if a drain accidentally pulls out, it may be possible to replace or reposition using a wire and fluoroscopy guidance, so don't forget this as an option. There are many ways to secure the catheter. I prefer a 2/0 silk suture with an air knot. After a drain is inserted, clinical follow-up by the proceduralist or IR team is ideal. Most abscess drains need to be flushed. Typically, I recommend 10 cc of water or saline twice a day. We don't routinely re-image unless there's a concern about a complication or a fistula, but endpoints for catheter removal are generally clinical and depend on the scenario, usually including resolution of pyrexia, normalization of white cells, and catheter drainage less than 15 mils per dray. So a few points for drainages. For abscesses, I generally prefer leaving a drain in rather than aspirating alone without leaving a catheter. After I place a drain, I always send a sample and aspirate the rest of the collection to dry into the drainage bag. There's low volume data on the use of fibrinolytics for loculated collections, but in the small volume of data that we do have, they do seem to improve short-term outcomes in loculated abdominal collections. The actual impact on morbidity or outcomes in pleural drains and abdominal drains is limited, and most guidelines don't routinely recommend it, but that doesn't mean it shouldn't be considered on a case-by-case basis. So whether you're doing a biopsy or a drain, there are several methods to improve access to a lesion that looks initially inaccessible. Gantry angulation is really useful when there's no clear route in the axial plane. I use this most commonly for subphrenic lesions such as adrenal lesions to avoid the pleura. This means your entry point is lower and the tract extends superiorly up to the lesion. This is particularly important if you're draining a septic source. You don't want to introduce infection into the pleural space and cause an empyema. If you do angle the gantry and you have a clear route, you want to mirror the angle of the gantry with your needle. If you can't angle the gantry enough, for instance, for this high posterior liver lesion, the out-of-plane technique can be used. This is where you start imaging at one position and follow your needle or intended path, ending up with the imaging at a slightly different position. And with experience and using small stacks that you can reconstruct, this technique is really useful. Hydrodissection is used more commonly for ablation techniques, but it can be really helpful for biopsy and drainage procedures too. This is the same liver lesion, and the 6 French drain anteriorly is infusing saline to artificially create ascites to lift the diaphragm, or lift the liver off the diaphragm. You often need quite a large volume, a few hundred mils or more, to displace a structure. Alano et al. Used this technique quite successfully for converting undrainable abdominal abscesses to drainable ones. If it's not possible to see the lesion with the modalities that you have, using landmarks can be helpful. For example, for a particular liver lesion, you might be able to see that it's adjacent to the right portal vein or immediately behind the right hepatic vein, and that can help target the correct lesion. And using the lesion depth and angulation can really help you here. Occasionally, even with all the tricks in the book, there's no access without traversing an intervening organ. After considering the alternatives, this can occasionally be warranted. For both transvaginal and transrectal procedures, I use ultrasound. I have to say, for transvaginal abscess management, I aspirate rather than place a drain more frequently than in any other situation, because it's difficult to secure the catheter and it can be uncomfortable for patients. Having said that, this approach can be useful for procedures in the vesico-uterine space or adjacent to the uterus. Transvaginal has high technical success rate and a tolerable complication rate. Complications are more often seen when drainage catheters are placed rather than needle aspirations. Transrectal drainage is another option, particularly for low pelvic access. If your patient has had recent rectal surgery, do be mindful of the anastomosis and have a discussion with the surgeons before you go ahead. Again, there's a high technical success rate for these procedures with a low complication rate and most frequently catheter dislodgement. The stomach and liver are also considered safe to traverse in most circumstances when no other option exists. The stomach is probably most often crossed endoscopically for drainage of pancreatic pseudocysts. There is limited data which suggests it's safe to traverse the stomach for biopsy, for example, for pancreatic biopsies, if there's no other route, particularly with a small gauge needle. It is important if you do traverse the liver to make sure that coagulation parameters are normal. Choose a short route through the liver and avoid a transhepatic route if there's biliary dilatation. Don't forget the transvenous options also, particularly for liver and renal biopsies. This is a renal cancer, which is high risk for a percutaneous biopsy because of the medial lesion location, but it was easily accessible by a transvenous approach. Navigation and fusion techniques can help a lot if they're available to you, particularly for challenging lesions. So post-procedural, the majority of complications occur within the first hour following biopsy. The very, very vast majority of complications occur within 3 to 4 hours. And that's why most institutions will monitor patients for about this length of time. If you're monitoring, you're looking for increasing pain, change in vital signs, which could indicate a possible complication. If there's any imaging necessary prior to discharge, for example, a repeat chest x-ray post-lung biopsy, make sure it's reviewed and acted on. The patient or their carer should be fully informed about post-procedural care, how to recognise potential complications and what to do if they do have concerns. In general terms, anticoagulation can be restarted about 24 hours after an uncomplicated biopsy. Extend that to 48 to 72 hours for NOACs, and occasionally sooner if there is a high thrombosis risk. And finally, it's ideal if follow-up is scheduled before the patient is discharged. Abscesses can be classified into 3 groups, organised by complexity. The unilocular abscess resolves with percutaneous drainage in 90% of cases. The medium complexity abscesses, such as those with communication to the GI tract, are fully resolved in 80 to 90% of cases. Even if surgery is necessary, it can be more straightforward if the fluid has been drained. The most Complicated abscesses are, for example, those intermixed with pancreatic abscess necrosis or infected tumour or tenacious organised connections. Particularly the infected tumour, like we see here, caution is needed, and a fistula can result and be difficult to manage. The resolution rate in these lesions is no higher than 80% and up to between 30 and 50% in some series. Overall, percutaneous interventions are really successful. The majority in the mid or high 90% range. SIR in a recent paper here have given these ranges for success rates and suggested QI thresholds for internal audit. Results of a percutaneous needle biopsy should be evaluated and discussed by an MDM team when necessary. When biopsy results are non-diagnostic or discordant to what is clinically suspected, a repeat biopsy should be considered, also considering different approaches or techniques, including surgical options. Obviously, all complications are best avoided, but even with the best planning, they do happen. The best advice I can give is to prepare well and try and anticipate the problems that could arise. Happily, most complications are minor. For drainages, the most common complications are catheter-related, such as occlusion or kinking or malposition, and these are usually easy to correct. Bleeding requiring intervention or transfusion in solid organ biopsy is rare, about 1 to 2% overall. Tract seeding, again, is rare in most series. Lung biopsies have their own complications. Pneumothorax is seen in about 25 to 35% higher with less than 18 gauge biopsy needles. Hemoptysis requiring therapy occurs in 2 to 4% of procedures. An air embolism is very uncommon, but very important to know how to manage. So in conclusion, percutaneous needle biopsy and abscess drainage are safe, effective procedures. They've really changed what used to be a significant operation to a much more benign procedure for the vast majority of our patients. Good communication with your patient about the procedure, possible complications, and how they may be treated is essential. With the correct technique and appropriate training and planning, it really is possible to safely reach almost every structure in the body. Thank you for listening.
Thank you, Heather. That was absolutely fantastic. And I'm pleased to tell you all that we have a whole session on interventional radiology at Radiopedia 2023. And specifically, this is a session on interventional oncology. There are 3 brand new lectures, including one by Heather on vascular interventional oncology. And one of those 11 encore lectures I mentioned previously is also by Heather. That's all we have for now. Do make sure you check out the conference registration website and also give our podcast a listen. I'll see you all soon. Bye-bye.